Bismillah ar-Rahman Rahim. First of all, I would like to thank Professor Tafazul and his entire team for giving me this honor to be part of the RheumaCon 2021. Um, Kawasaki disease and multisystem inflammatory syndrome in children. I think multisystem inflammatory syndrome in children has really raised a new interest into the Kawasaki disease. So I will be spending first 10 minutes on Kawasaki disease and then another few minutes on MISC before closing my talk. Kawasaki disease is an acute self-limited febrile illness. We know that for last 4 decades, it is of unknown etiology that predominantly affects children. In Pakistan, it is the 4th common acquired heart disease after rheumatic heart disease, myocardial disease, and pericardial disease. Although in the West, now it is the common acquired heart disease in children. The highest relative risk in Asian children comes from Japan, where the annual incidence is over 250 per 100,000 children under 5 years of age. So very high prevalence in Far East, particularly in Japan. It particularly occurs in winter and early spring, more common in boys than girls, and about 76% are under 5 years of age. So it's a disease of children under 5 years of age. The particular relevance of this disease comes from coronary artery disease, which is aneurysm formation. And now in certain parts of the world, up to 5% of acute coronary syndromes, which occur in adults under 40 years of age, have history of coronary artery disease from Kawasaki disease. The etiology and pathogenesis, as I said earlier, remains unknown. Particularly the etiology remains unknown. It's an acute self-limiting vasculitis, which particularly affects coronary arteries. And the pathogenetic hypothesis supports an aberrant response to the immune system to one or more unidentified pathogens. And since the MISC has come in post-COVID, many people think that this is an post-viral syndrome, novel RNA virus that enters through the upper respiratory tract and causes this aberrant response. One strong feature about Kawasaki disease, and I think that is true for MISC as well, is genetically predisposition. We know that there's an increased incidence among Japanese children, not only within Japan, but people who have immigrated from Japan and are living outside Japan, the incidence of Kawasaki disease is higher. Similarly, incidence among parents is higher, and among siblings and extended family members is also high, clearly giving a genetic predisposition. When we look at the pathology, the Kawasaki disease vasculopathy primarily involves muscular arteries, and that's particularly true for coronary arteries. 3 linked processes: necrotizing arteritis, subacute or chronic vasculitis, and luminal myofibroblastic proliferation. Now, this third component is particularly crucial because this gives potential to progressive arterial stenosis, which occurs in these patients in older age group. In acute stage, pericarditis and myocarditis also occur, but they're usually, although the inflammation is usually concentrated around coronary arteries. And one important thing to remember is that atherosclerosis is not a feature of Kawasaki disease. What occurs in Kawasaki disease is aneurysm formation, and that has been actually documented in late deaths as well as in transplanted patients with Kawasaki disease. The diagnosis is completely clinical. There are principal clinical features, and you need to have a fever of more than 101 degrees persisting for at least 5 days with 4 out of following 5 features: bilateral conjunctivitis, oral features of which strawberry tongue and erythema and cracking of lips are characteristics, rash, swelling of hands and feet, and unilateral cervical adenopathy. So out of these 5, you need to have 4 features. If you fall short of these 4 features, then you would consider atypical or incomplete Kawasaki disease. But if you find coronary involvement, it is Kawasaki disease, full stop. Then you don't need the full criteria, and I will be talking about that in a moment. Just to explain slightly the characteristic rash, which occurs within 5 days of onset of fever, it is usually a diffuse macular papular eruption, but it can be erythema multiforme-like rashes, or scarlentiform erythroderma. Conjunctivitis is classically bilateral. It's non-purulent, non-exudative, and usually begins shortly after onset of fever. And one characteristic feature is that it spares the limbus. The avascular zone around the iris, it is almost always spared. In terms of changes in the lips and oral cavity, you get erythema, you get dryness, you get fissuring and peeling and bleeding of the lips. Strawberry tongue is again a characteristic feature of Kawasaki disease. And you can see the classical picture being shown over here. You can see diffuse erythema of the oropharynx as well. Hands and feet features are also very classical. First, you get erythema and redness, which occurs with the acute stage, and that can be accompanied by painful induration. And then you get this classical desquamation, which starts in the periungual region and then can extend onto the palms of both hands and feet. Lymphadenopathy, fortunately, is the least common. It's classically unilateral and it affects the anterior cervical triangle. Now, atypical or incomplete Kawasaki diseases when you have less than 4 features. And it classically affects infants under 1 year of age. And because you don't get the involvement of coronary arteries until the first week of illness or the end of the first week of illness, it's important to recognize this entity separately. So one of the crucial features here is coronary artery involvement. If you must Z-score coronaries. If you're doing an echocardiogram and if you have a coronary Z-score of between 2 and 2.5 involving either left or right coronary artery, this is highly specific for incomplete or atypical Kawasaki disease. To just summarize that particular aspect, if you have a fever of more than 5 days and 2 or 3 compatible clinical features, go and get their acute phase reactants. If they are raised, then you should look for other laboratory findings like anemia, platelet count over 450, hypoalbuminemia, raised ALT, white cell count above 15,000, or sterile pyuria. If you have 3 or more laboratory parameters with raised acute phase reactants or 2 or 3 clinical features, you are dealing with atypical Kawasaki disease. But if you don't get any of these, but you have a positive echocardiogram, it's Kawasaki disease, full stop. Aneurysm or dilatation of coronary arteries in an acute febrile illness is Kawasaki disease. Of course, if your acute phase reactants are low, then you need to follow these patients with a serial echocardiogram. 5% of patients with Kawasaki present in a shock. And this is also called Kawasaki Shock Syndrome. You will get often severe abdominal pain. Your platelets would be decreased rather than being raised. You will have raised acute phase reactants, raised D-dimers, raised hepatic enzymes. These patients are often IVIG resistant too, and their troponin and CKMB would be raised, confirming myocardial involvement. These are very sick patients, and unless you pick them early, this can lead to a fatal outcome. Now, in a country like Pakistan, you must be able to differentiate Kawasaki disease from other important conditions which are far more common. Measles, viral infections like adenovirus, enteroviruses, streptococcal toxin-mediated disease like scarlet fever or toxic shock syndrome, and drug hypersensitivity reactions like Stevens-Johnson or systemic onset juvenile idiopathic arthritis. Now, these are all more common than Kawasaki disease. And of course, if you have an epidemiological risk factor, you will consider rickettsial infections like Rocky Mountain spotted fever or leptospirosis. But this day, the most important differential diagnosis is post-COVID multisystem inflammatory disease in children, which is temporarily associated with SARS-CoV-2. Now, in terms of labs, your white cell counts may be normal or elevated, but what is crucial is that your acute phase reactants must be elevated. You must have a raised CRP and ESR. You may have a low serum sodium or albumin, liver enzyme, sterile pyuria, as I mentioned earlier. But one of the characteristic features of Kawasaki disease is thrombocytosis, raised platelet count. But the problem with raised platelet count is by the time platelet count rises, it's already too late to treat them with IVIG. So the diagnosis of Kawasaki disease, if you have not made it until the platelets have raised, you have actually missed the diagnosis. And you have missed that opportunity where you could treat them with IVIG. But they characteristically rise in second week, peak in third week, and then start normalizing in fourth or fifth week. Invariably, these patients would have cardiovascular involvement. All three layers may be involved. Myocardium in up to 20%, but the characteristic feature is that this is self-limiting and transient. Your LV function recovers fairly quickly. You may have a small pericardial effusion or trace to mild MR in up to 1/4 of these patients. But what is specific and supportive is coronary artery abnormalities. And they are present in up to 23% if you don't treat them with IG. Of course, you can reduce the incidence very significantly if you treat them with IVIG. I think it's important to understand how coronaries are involved. Coronary artery abnormalities range from dilatation only up to major massive aneurysms. We define an aneurysm if your subsequent or adjacent area is more than 1.5 to the area which you are referring to. But the areas which are most commonly affected are right coronary artery and branches of the left coronary artery. Left main is very rarely involved. And because you see left main dilatation anyway, it can be misleading as well. So up to 40 to 70% would involve right, 32% will involve LAD, and up to 23% left circumference. Majority would have dilatation only, but if you get an aneurysm, remember, they can be massive aneurysms. And all other medium-sized vessels may be involved. As you can see in this picture, your subclavian arteries, axillary arteries, renal arteries, iliac arteries, and even mesenteric vessels can be involved. And unless you actually screen these patients for these, you may be missing them. Now, one of the crucial investigations in these patients is doing an echocardiogram. And I think doing a good echo is crucial. As you can see, I put a picture in the middle and two echoes on the top and the bottom, and you can see marked dilatation of left coronary artery as well as right coronary artery. Right Meyer's 5.7, left Meyer's 7. Right Meyer's 7.3, left Meyer's up to 5.7. And these aneurysms are characteristic. You may have small, medium, or large aneurysms, and we define them either by their actual size, which is if it is more than 4, it's medium. If it's more than 8, it's large. Or you actually Z-score. And how do we, if there's no involvement, your Z-score coronary artery will be less than 2. If your Z-score is between 2 to 2.5, it's dilatation only. If it's between 2.5 and 5, it's a small aneurysm. Up to 10 is a moderate, and more than 10 is a large aneurysm. We hardly ever do a CT, MRI, or invasive angio in an acute patient. Of course, in the follow-up, you would be needing them if you genuinely want to look at these coronary artery aneurysms. Now, management. I think the goal is to reduce inflammation and prevent arterial damage and prevent thrombosis in coronary arteries. And mainstay of treatment is IVIG. You must start, if in doubt, give IVIG. I know it's an expensive treatment and not everybody will be able to afford that, but I think we need to put in all resources to treat these patients. 2 grams per kilogram as a single infusion given over 10 to 12 hours. And if the diagnosis even has been missed, and if it's more than 10 days, you should still consider it if your ESR or CRP is raised. Aspirin, 80 to 100 milligram per kilogram, and you continue it until the child is afebrile for at least 3 days. Of course, low dose aspirin needs to be continued afterwards, particularly if there is evidence of coronary artery involvement, and indefinitely if there is coronary artery involvement. Steroids, as usual, are controversial in patients with Kawasaki disease, but a recent meta-analysis has shown that if you combine steroids with IVIG in high-risk patients, you can further reduce the risk of coronary artery abnormalities. So there is a place for steroids if IVIG is not available, or if it's a high-risk patient who is not responding to IVIG, then you can jointly give steroids and IVIG. Infliximab in resistant patients, cyclosporin also in refractory cases, and of course, immunomodulated modulatory monoclonal antibody therapy or cytotoxic drugs are extremely rarely. Plasma exchange is done for highly refractory patients, which we rarely see with Kawasaki disease. This is a very busy slide, but I thought I will mention only two things here. One, all patients with Kawasaki are risk stratified, and that risk stratification is based on coronary involvement. If there is no involvement, it's 1, dilatation only 2, and then small aneurysm 3, medium 4, and large aneurysm 5. And all its importance is whether you're going to give them aspirin, combination of aspirin and clopidogrel, or anticoagulation. Anticoagulation is only indicated if it's a large, giant, persistent aneurysm. Otherwise, for moderate to large, a combination, and for a small to dilatation only, aspirin is given. I would spend another 5 minutes on MISC here, because I think that multisystem inflammatory syndrome in children, which is temporarily associated with SARS-CoV-2, was first reported in London and Italy, and subsequently we also reported it in the literature from Pakistan. And Kawasaki disease-like syndrome with a higher rate of cardiac involvement and features which are somewhere with Kawasaki syndrome and Kawasaki disease. So I think in pediatric age group, the most important reason why COVID is important is actually MISC. The timing is usually 2 to 6 weeks after COVID peak. Majority were negative for SARS-CoV when we checked for their sort of virus isolation, but all were positive for antibodies. So this clearly suggests that this is an abnormal immune response, which is either antibody or T cell mediated, and it's not a direct viral injury. This is post-COVID syndrome. And I think this has started, people have started thinking as well that Kawasaki disease is most likely also a post-viral disease. Case definition for MISC, slightly different from Kawasaki disease. Any child who is under 19 with COVID exposure and presented with fever for more than 3 days, and any two of the following: symptoms of Kawasaki disease like rash, conjunctivitis, mucosal inflammation, systemic illness with signs of hypotension or shock, features of myocardial dysfunction, which obviously you can see either by echo or by raised troponin and pro-BNP, evidence of coagulopathy. And one characteristic feature of MISC is abdominal symptoms, GI symptoms. Not uncommonly, they present with vomiting, diarrhea, and abdominal pain. So any two of the following, along with fever, and if you have raised markers of inflammation and your COVID antibodies are positive, it's MISC. Of course, it's crucial to make sure that you are either PCR positive or you have COVID antibodies. Of course, you need to exclude other plausible causes as well, but presence of COVID antibodies under these circumstances will make a diagnosis of MISC. Classical features: fever for more than 3 days, GI symptoms, feeling unusually tired, all the features of Kawasaki disease. Another important symptom in MISC is neurocognitive: headache, lethargy, confusion. Some of them will present with shock or acute heart failure. But remember, respiratory symptoms are very uncommon. They are not a feature of MISC. Like any other disease, we have a spectrum of patients presenting with MISC. Those who only present with mild symptoms like headache, fatigue, and inflammatory markers may be raised, and those who present with severe shock-like condition, which we call as acute cardiogenic shock. And I think majority would fall in the middle, which is something which resembles Kawasaki disease-like illness, whether complete or incomplete Kawasaki disease. Those who present with Kawasaki disease would either meet criteria for Kawasaki disease or will meet criteria for incomplete Kawasaki disease. And those who present with shock or cardiac involvement resemble more with myocarditis. And they would have features very similar to acute myocardial dysfunction. Differential diagnosis, I think, like any other condition, background conditions, both Kawasaki disease and viral myocarditis bacterial septicemia, toxic shock syndrome, hemophagocytic lymphohistiocytosis. And I must tell you that at least 3 patients in our series, which we have also reported in the literature, presented and were misdiagnosed as appendicitis or acute abdomen. It was only subsequently that we found out that these patients had MISC. We must differentiate Kawasaki disease from MISC. Now, there are classical features which differentiate the two. Kawasaki disease classically affects under 5 years. MISC classically affects 5 to 15. So that's one of the major differentiating points. GI symptoms are far less common in Kawasaki than in MISC. Myocardial dysfunction similarly is far more common in MISC than Kawasaki disease. Inflammatory markers are raised in both, but are far more elevated in multisystem inflammatory syndrome. Similarly, absolute lymphocyte count is lower than Kawasaki disease, and coronary aneurysm are far more common in Kawasaki disease than in MISC. Although you see dilatation of coronary arteries in multisystem inflammatory syndrome, but aneurysms are far less common. These are the skin manifestations of one of our patients who presented with MISC. You can see strawberry tongue, conjunctivitis, peeling of the skin from hands, and these are the features which you see with Kawasaki disease as well. How do we evaluate them? I think 5 to 15 years of age, male predominance, they are usually well-appearing children and initially did not have symptoms of COVID. This is important. Most of these patients do not have symptoms of COVID. As most of you would know, that COVID in children is a relatively rare disease. They don't come in with serious symptoms, but if you find a history of contact, that would be there in up to 1/3 of patients. And they present with Kawasaki disease-like illness. What you need to be worried about is if they present with shock, myocardial dysfunction, or signs of meningism, because then they can deteriorate very quickly. Lab, full blood count, C-reactive proteins. You classically see lymphocytopenia, neutrophilia, and thrombocytopenia. Acute inflammatory markers are markedly raised, CRP, ESR, serum ferritin. You can exclude a bacterial infection by looking at procalcitonin level. Cardiac markers are often raised, and you would see that their coagulation studies would show raised PTA-PTT. Now, what is crucial is presence of COVID-19 antibodies. You may have RT-PCR positive as well. And of course, all these patients must get an echocardiogram done. Of course, you can do a X-ray, ECG, and abdominal ultrasound as well. Now, how does the management differ from Kawasaki disease? I think MISC presents far more acutely. Abnormal vital signs, respiratory distress, neurological deficit, evidence of renal or hepatic injury, markedly raised inflammatory markers, abnormal EKG, all favor acute shock-like syndrome. They present with warm vasoplegic shock and can be very resistant to volume resuscitation. One important point as a healthcare worker, please wear personal protective equipment if you are dealing with a patient with MISC, and the approach is obviously multidisciplinary. This is rather a busy slide, so I would split it into two. If you see a mild to moderate illness, which resembles Kawasaki disease, the management algorithm is exactly the same. IVIG, aspirin, and you only consider steroids if fever does not settle after IVIG. And you discharge them on aspirin 3 to 5 milligram per kilogram. But if they present with shock, then they need to be admitted in an intensive care unit. They need to be put on broad spectrum antibiotics. Not uncommonly, you will have to ventilate them. They need an urgent cardiology consultation. They need to be put on inotropic support. And these patients should be considered for a dual therapy for both IVIG and steroids. So we give IVIG 2 grams per kilogram, steroids as pulse therapy, methylprednisolone 10 to 30 milligram per kilogram for 3 days, and then you taper them down. Tocilizumab is only indicated if you see a cytokine storm, so extremely rarely indicated. But what you must think seriously is enoxaparin. 0.75 milligram per kilogram. You can, of course, give the dose according to the age, and this should be given prophylactically to almost all sick patients who present with MISC. Remdesivir, not indicated. It's not a viral infection. It's a post-viral infection. Similarly, if you see severe cardiac dysfunction, the management is same as for myocarditis. Supportive treatment, steroid IVIG, inotropic support, captopril, anticoagulation. Majority of these patients do extremely well. We have seen only one death in our series, which now is over 3 dozen of patients. They should be followed up, of course, a multidisciplinary team, including a pediatrician, a cardiologist, and of course, a rheumatologist if you have available. We hardly have a pediatric rheumatologist available. So our pediatricians actually look after these patients as a multidisciplinary team. Outcome, fortunately, both for Kawasaki disease and MISC is mostly very good. What is crucial is to make an early diagnosis. If you treat them with IVIG and steroids, majority of them do extremely well and would recover completely. Of course, there is a mortality, and that mortality is usually related to a delayed diagnosis and ventricular dysfunction. This is our own initial experience. You can see with MISC that fever was almost invariable, GI symptoms in a lot of patients, conjunctivitis in 87% of them, oral mucosal changes in more than 50%. Ventricular dysfunction is relatively rare, which is a good thing, but you can see almost all of them had IgG, IgM antibodies against COVID-19. And of course, majority were given IVIG. A small proportion was also given up to 1/3 in steroids. Only one patient, actually 6 of them needed intensive care. And you can see we had one mortality as well in these patients. I would like to conclude by saying that Kawasaki disease and MISC are self-limiting febrile illnesses. They are usually an aberrant response of the immune system to most likely a viral pathogen. Of course, for sure in MISC, but most likely in Kawasaki disease as well. But it occurs in genetically predisposed subjects. That's why not all children who are exposed to COVID-19 are getting MISC. The current incidence is somewhere between 500 or so. If 500 children are getting COVID, only one of them would actually develop MISC. Diagnosis is clinical, except in MISC, where I think presence of post-COVID antibodies is a must. Majority responds to IVIG. So treatment at the moment is expensive. IVIG are very expensive. And of course, you should put them on anti-inflammatory treatment as well, which is aspirin. And a selective group, depending upon the severity, would also need steroids. The good thing is prognosis is very good. But I think if an in-time diagnosis is made, an in-time treatment with IVIG is given. And coronary artery involvement requires a lifelong follow-up. And as I said in my very first slide, up to 5% of adults presenting with acute coronary syndrome had undiagnosed coronary artery disease secondary to Kawasaki disease. So it's an important condition to be considered in these patients too. Thank you very much.